We'll give it a couple of minutes here.
Yeah, I don't see the interpreter has not come back on yet.
Mary, how was your listening session last night in Tarboro?
It was very good. It was very good. I'll talk a little bit about it when I do my remarks,
Yeah.
but considering the weather, it was very well attended and very
I
engaged
signed
folks.
up to go, but I got attacked by sinus infection and there was just no way I could.
Oh dear.
So,
Yeah. Weather didn't help either. The worst, there was only one drawback on it was having to drive in the rain. When you don't drive that well in rain at night, it makes for a long drive back for sure. We'll let the magic number at least get to 30 before we start. You see the interpreter, Sandra, back
No, I
on?
do not.
Okay.
I'm not
Maybe
sure
we'll
what was
wait.
happening on that end.
Yeah. So we'll wait just one more minute and see if she can get back on. If not, we've got we'll let y'all explain what services we do have and the all righty. There we go. All right. Just in being conscious of everybody's time, I think we probably will get started. So good morning,
We
everybody.
we do have the
Glad y'all.
closed captioning.
Yeah, we'll talk. I'll let you explain,
Okay.
you and the
Okay.
folks explain. Thank y'all for being here today. It is a kind of dreary Friday, but we need the rain, so looks like the weekend's going to be pretty decent. So we'll just have to get through today and do that. So if you hadn't gone to vote yet, vote. Yeah, polls close tomorrow, I think at 3 o'clock. So encourage everybody to do that for sure. But let's get started with the agenda. Sandra, I'm going to turn it over to you to talk. I know we've had a little bit of interpreter problems with the computer. Let you and folks from Division of Health Services, from Services for Deaf and Hard of Hearing, talk about our services today.
Okay. Thank you all for being here. And again, there goes Erica. We found her. I'm going to let Catherine. I haven't learned the wording that you use to make sure anybody who needs the interpreter services are able to access either closed captioning or the ASL. So I'm going to let you explain to the folks, anybody who wishes to do that for the meeting today.
Sure. This is Catherine. Good morning, everyone. So today we will have American Sign Language interpreters here in the meeting. We will also have communication access real-time translation, also known as CART. If you'd like to access the CART captioning through your Zoom screen, you can look at the bottom of your screen for that More button. Click on that and select Show Captions. That will pop up and you will be able to adjust your captions as needed. There might be an external link. I'm not sure if the captioner is going to have an external link today, but at the very least, you should be able to access the captions in Zoom. You can adjust the font size and color for accessibility. And for ASL users, you can click on the three dots next to the interpreter's name and select Pin to view the interpreter larger. When we have a presenter, if they have a PowerPoint on the screen, you can select side-by-side gallery view at the top right of your screen and pin the interpreter and hover the video and PowerPoint to drag and adjust your screen as needed. And that's all I've got for you. Let us know if you have any questions or have any other needs. Thank you.
Thank you, Catherine. We appreciate that. Thank you guys for being here. So thank y'all. Those of you that already signed into the chat, if you don't mind, do sign in with your name and or at least organization and anything else you want to say also. But we appreciate that. That helps us kind of keep track of who's here and what's going on. So you were sent the minutes from the January meeting with the announcement or reminder about this meeting. Anybody have any questions relative to the minutes that were sent? Okay, I don't see any. So, but I recognize Lee Little instead of Sandra because Lee is our Secretary Treasurer and he is here today. So, Lee, I'm gonna turn it over to you to just give a brief Treasurer's report.
Okay. Good morning, everyone. Just wanted to report out on our financials as we ended the 2025 fiscal year and the beginning of 2026. Thus so far, the expenses has been relatively routine, such as the fee for Zoom meetings and some office phones. We're fortunate, wanted to report that is that we're fortunate to receive the Z. Smith Reynolds Foundation's grant that will allow us now and in the future for additional staffing to support the work that the coalition is doing. We also want to thank United Healthcare and their renewal for their premium level partnership that we do each year. There are still some partnership opportunities available this year for others. Wanted to make that. And we also wanted to say since January 1st that there have been about 22 individuals and 28 organizations that have already renewed their membership. So I will put in a plug for everyone to get in their memberships for this fiscal year as soon as possible. You should be seeing a renew emails and a reminder in your inbox. Thank you.
All right, thank you, Lee. Any questions for Lee on anything? And if y'all don't know Lee, Lee is now with Wake County Human Services. He when we first met Lee, he was with Durham County Social Services, but I think got a promotion or at least changed jobs. I think got a promotion too, and moved to Wake County last year. What did Lee?
Yes.
Yeah,
Mhm.
yep. So thanks much, and he's a great addition to our board. So we appreciate it, Lee.
Oh,
All
thank
right.
you.
Yes. All righty. Let's move on. Sandra, I'm gonna turn it over to you for an update from you.
Okay, very good. Thank you, everybody, for joining us. It always does my heart good to see everybody who I know are so busy choose to take time to join the coalition meetings on a monthly basis, and that tells me that we are providing information that you find valuable, and I just appreciate your time, and I wanted to say that. Uh, and if since it's February, if I could send roses to all of you, I would. But so,
I'm not sure the budget would allow for that, but anyway, if you want
well.
to do it personally, you go right ahead.
I might get a discount now since it's after Valentine's.
True.
um, February has been a busy month, a quick month, but I've been busy. Of course, if you've been seeing some of those reminders going out about the membership, trying to keep on track of that this year, we have had a good response to that, and so you will probably be seeing future reminders of that, and we're going to be doing some more outreach to try to increase those numbers. Our goal this year, or our budget, is to have 100 individuals and 90 organizations. So I think that is very attainable, and that will be part of my new role as the operations director to do that kind of work. I've also been attending some various webinars and different meetings in the past month. Some are recurring meetings, such as the finance committee subgroup of the All Ages, All Stages, looking at different ways that we can help promote retirement goals, looking helping people, younger folks, when they're in their 20s, look forward to make sure that they, as much as possible, can start planning for their retirement even that early. Um, I also attended an audit and tax webinar, which was for nonprofits. That was very exciting, as you can imagine, audit and tax updates. But it is very important information to learn, what has changed. Some things are more apply more to larger organizations, but it's always important to keep on top of those kind of items. Um, I'm also as part of the role that I play. I've been attending the Coalition for Dementia Capable North Carolina meetings, which is very good to understand what's happening in that realm and how we at the coalition may be able to provide support or just offer assistance in any way we can. Also, the essential jobs, essential care, that for those of you that have been with us for a while know that we kind of kick-started that a few years ago. And as of January, that is now being coordinated with the Center for the Workforce on Health. And that's Trish Farnham, who used to work with the coalition, is kind of coordinating that. But we still have a part in that and kind of serve in that advisory role that committee has now taken on. So that's an important connection that we want to keep. Yesterday, I also attended the North Carolina, it was the North Carolina Roots Hub Information Webinar. And this is related to the Rural Health Transformation Grant that DHHS received through the federal funds. It's very interesting. They have done a lot of work. If you don't realize that, they have to do a first report in August of this year. And I think they just got recognized for funding in December. So they're really trying to fast track a lot of things. And if you have not looked at that information, they did have a PowerPoint yesterday that kind of explained the 6 areas that they're looking for. I think it's very good information for all of us to kind of know what's happening in that realm. Also going to be starting gathering, again, going back to that audit and tax information, looking to make sure that we've got all of our items together for our 990, which is our IRS form that as a nonprofit we have to file. So that's very important to keep on top of those things, as you know, Teresa Troop. Also, coming up this week, I'm going to be attending the Legacy Speaker Series at UNC Chapel Hill. It's through their School of Social Work. It's going to be a very good, informative program. And I'm looking forward to that and meeting some more folks related to older adults and aging issues in North Carolina. Just a couple of other things. I'm also on the Older American Month committee for North Carolina, and we're working on some ideas. That is the month of May. I will just tease. I'm not sure if Misty is on here, Misty Picard from the DHHS, tease that we're working to have the governor participate at some possible level. So, Misty, I'm not speaking out of turn too much, but maybe just to encourage folks to look for that announcement about the activities that are going to be surrounding that coming up in May. Other than that, it hasn't been too busy. So, I think that's all I have. I know Mary's got some things. We all know Mary's always involved in something, so she's been going here and yon for the last month. So I'll let her talk about some of the things she's been doing to represent the coalition.
Thank you, Sandra, and thank you for all you're doing to stay on top of the membership. Quite frankly, we had kind of let things slide when it came to sending out invoices for notices and things like that. So we're getting back on top of that. It was one of those things we've kind of fell through the crack. Yeah, there's a lot going on, as Sandra said. Just to pick up a little bit about the rural health transformation grants that Sandra mentioned. The RFA for the root hubs, which are going to be the regional groups that are going to be coordinating that is going on, I believe it's this afternoon. And there's a short turnaround for getting that back in. But, this is a great opportunity to increase healthcare services in rural communities in North Carolina. And one of the things that's going to be really important for those hubs to do is they're basically going to be coordinating everything that's going on. And they're going to be doing that with partners. So I would encourage those of you at the local level, or those of you that work with folks at the local level, think about if they want to be engaged as a partner. Now, the role of a partner is to basically they're looking at partners across behavioral health, workforce development, primary care, value-based payment, and digital health are the things that they list. But I think lots of the services that all our groups provide certainly fall into those areas some. So I would encourage you, after you find out who these root hubs are going to be, if you are interested in being engaged, contact them and find out what's going to be involved in the process. And do it in the early stages. I think you'll have more opportunity for input and engagement. Y'all probably saw an announcement that went out this week that Tammy Koger, who has been the deputy director of the Division of Aging since I believe it's October, is going to be the new director of the division effective March 1st. So I've had the opportunity, and I think Sandra too, to work with Tammy some. Certainly, she brings a lot of skills and abilities to that position. She and I, excuse me, along with Steve Friedman, who worked at the Division of Aging, I think, for 49 years as Chief of Service Operations. We actually did a session on Monday it's called the Legislative Health Policy Fellows. And what this is new legislators that want to learn more about health issues. The Institute of Medicine pulls together a series of sessions every year for these new legislators or people who want to learn more about health policy, and they bring in people from the different human service areas, including aging, to come and talk to the legislators. So we had the opportunity, the three of us, to talk to them on Monday about aging issues, and they were very, very engaged and had a lot of questions. And we also took the opportunity to kind of plug things like we need more money, and that services, are not uniform across the state, and a lot of that has to do with finances, things of that nature. So hopefully we'll see some good results from those folks that have gone through these educational sessions. The Governor's Advisory Council each year makes a report available to the governor, and they sent the report for this year in on January 30th. I don't know if Bill Lamb's on here. I haven't seen him. Sandra, I don't know if you see him or not. If he is, he might want to say you're on.
So I'm here.
Okay, Bill, why don't you say a few words about the report that went to the governor?
So we had a report that went to the governor, and what we really tried to do was to summarize the key points in the all ages, all stages plan, and really kind of outlined for this governor what actions they need to focus on in the next year or the beginning year of this administration. We also wanted to encourage him to think about it, and we're actually working on this now, an opportunity to restart, to have an event in Older Americans Month, May, where he could speak to the various interest groups who were on the ground floor of the all ages, all stages plan, and to own it. To this is no longer Cooper's plan, but it's going to be the implementation stage is really going to be under Governor Stein. So that was the primary message of the report.
Yeah. Thank you, Bill. The Governor's Advisory Council, per Executive Order 280, which set up the process for the multi-sector plan on aging, had a very defined role for the Governor's Advisory Council on Aging to basically kind of look at things and to offer recommendations and oversight relative to the plan and moving forward on that. So that's what the Governor's Advisory Council did. So, Bill, thank you for that. Really appreciate it. We've got a newsletter that will be going out this afternoon, and then we'll resend it the first of the week also. But we try to cover, highlights of things going on. And one of the things I think that certainly has been significant that I really picked up on, and you guys probably did too, is a drop in the enrollment in the Affordable Care Act in North Carolina. North Carolina had the largest drop in enrollment of all states in the country, 22% drop in people from what was on there last year. We had this year, 2026, 761,457 people to enroll. Last year, we had 975,000 people. So, a lot of reasons for that. I mean, premiums went up, the subsidies went away, there are less navigators to help people, all those things. But, that means that a lot of folks may not have health insurance now that did have health insurance. What I'm also hearing is that a lot of people that did sign up this year went with higher deductible plans. So, meaning they'll have to pay out of pocket more. And there's an anticipation that a lot of people, as the year goes on, if they find it more challenging to pay the premiums, they'll drop the policies during the year. So, I think that is something that we really, it's going to be tough for a lot of people with healthcare challenges. We've had changes at the Medicaid level in North Carolina, and we've got a lot going on with Medicaid right now. I mean, they're working very, very hard on looking at all the provisions regarding the new work requirements for Medicaid that go into effect on January 1st. And I know we had speakers at the last meeting that talked about the work requirements, particularly as it related to caregivers. So after that meeting, the coalition sent a letter to Secretary Sanvey for Health and Human Services, as well as to the leadership of the Medicaid agency and with the person in the governor's staff that deals with health issues, basically just offered our recommendations of things that we thought ought to be considered as they are developing those work requirements. We focused a lot just on general comments, but we also did have a lot to say about what we thought needs to be done to ensure that family caregivers are protected and that they are protected in ways that don't require them to go through a lot of hoops in order to keep proving their eligibility, things like that. So I know that other organizations and groups have done this. Many members of this coalition have told me they've also sent letters. If you have a dog in this fight and you are interested, I would encourage you to also send a letter now, because those decisions are being made. I mentioned that they are going through kind of changes. Jay Ludlam, who's been the Medicaid director and done a very admirable job for many years, has left, or he may still be on vacation leave, might technically not be off the payroll, but he has gone. He's left the agency. He has gone to work for Molina Healthcare. And Melanie Bush, who was the second in command there, has been made the interim deputy secretary for North Carolina Medicaid. She used to work for the General Assembly, just really, really knowledgeable, does a great job. So hopefully there won't be any skipping beats with this transition in leadership. But they're also working on the deadline of the fact that, they don't have enough money to last for Medicaid until the end of the year. And we are not sure what the legislature is going to do on that. We think they will come back at some point and appropriate the money before everything runs out. But that's something else that they are contending with right now also. Just one other thing relative to state type things, Sandra alluded to this, and Lee also, is the fact that with this Z. Smith Reynolds grant we got, we are able to expand the staff of the coalition to another staff member, as we announced at the last meeting we had. And we are actually recruiting right now for a new executive director. We've had the job posted out for a month. We're going to keep it posted until March the 4th. If you know of anyone interested, but after that we're closing it. So information about the position and what you need to do to put your name in the pot is posted on the Coalition on Aging's website, as well as when the newsletter goes out this afternoon, it will have more information in there with all the links and everything too. So looking at things on the legislative front, let's talk a little bit about Congress and what's going on there. We know we had a short shutdown, 3 days. It I think came back in. Government started functioning again because they finally approved most of the budgets again, and it came back effective February 3rd. But we do know there's still one departmental budget that has not approved, and that's been for the Department of Homeland Security. And there's a lot of disagreement about moving forward on that budget. Democrats are holding out votes because of their concerns about the immigration and customs enforcement efforts. This budget also, in addition, including things like immigration and customs enforcement funded, include things for TSA and FEMA funding, things of that nature. So Congress was on vacation. Everything should be back. They should be functioning back full steam now. So hopefully we'll see some movement on trying to come to resolution relative to that. We know that the funding for aging programs, a lot of it in Health and Human Services, some of it Department of Labor, other types of things, all that was finalized with the new budgets that the president signed, the first of the year, or um, end of January. And basically, most of the funding for critical aging services was protected in that. When you get the newsletter this time, there will be a link to a chart in there that will show you the funding for 2024, 2025, and 2026. So you'll get to see how the funding shook out there. In the HHH funding that was approved, there was a lot said in the budget about healthcare extender measures. And that includes things like expanding the telehealth program, the hospital care at home care program, things of that nature. There was also a provision in there about ensuring that Medicare Advantage plans, that their ghost networks were cleaned up. And that's sometimes ghost networks, or what you refer to, is when they have a big provider list, but then people start calling those providers and try to get services and find out that providers aren't providing those services anymore, or are not members of a network. So some big things about cleaning that up. Switching gears to the state level, as we know, we still do not have a comprehensive budget, and we don't know when we'll get one. There, with the election coming up on Tuesday, that may determine what and if the General Assembly acts on. I think they'll act on Medicaid funding, but whether they'll do anything else other than that might have big implications for that. We're hoping that they will at least come back in April. They're starting the regular short session in April, but they also got a time to meet before that too. We still have some programs in North Carolina related to aging that have not received funding yet for this year. So it's a tough go for programs that had relied on state funding that aren't getting that. But we'll see what happens on that. Somebody mentioned what the program in Tarboro last night. What that was, Governor Stein has established what he's called a Stronger NC Governor's Advisory Council. And that is made up of representatives from a lot of different councils and programs that are already in existence that the answer to the governor or provide reports to the governor, as well as state agency representatives. Bill Lamb and I are members of the Governor's Advisory Council on Aging, and we were selected to be the representatives from the Governor's Advisory Council on that. And what this council is doing is going around the state and doing listening sessions to get input from the citizens of North Carolina, basically regarding what they think about the state of things is and their recommendations for things that need to be done. So there are 6 areas that they're looking at: workforce and economic development, education, health and well-being, public safety, and constituent services. I'm sorry, it's just 5 areas, I said. So as I said, it was a very engaged group in Tarboro last night. That was the first one they've done. And people didn't hold back on where they thought things stood and what they thought ought to be done in North Carolina. I think there was a general agreement among folks that rural communities are being left behind in many cases, and that the state needs to do more to basically offer incentives or grants or assistance in some way to help rural communities catch up. Broadband, for instance, was a big issue that people brought up still, because a lot of people don't have access to that still. A lot about they want to hold governmental officials accountable if they don't see results from what they think need to be done. But people had very concrete recommendations about things they felt were important for North Carolina to do. And the statement was made by a couple of people at the table I was working at. It says, when I go and look at other counties like Wake or Mecklenburg or whatever, and then I come home, my county is in many ways is where it was 20 years ago.
Right.
And we need to be engaged also in the economic prosperity that many other areas of the state are involved in. So things like jobs and economic incentives for businesses and healthcare workers came up a lot. Things like, also just healthcare in general, get into appointments and, if you can find a doctor or a healthcare provider. But they were talking about physician extenders, utilizing those more. They were talking about things like, working with youth more on things like financial, increasing their knowledge about the finances and the fact that, there's things like budgeting and things like that. And they were seeing with so many things that with our youth, we don't want to wait until they're in middle school or high school to start working for it. We've got to have interventions in elementary school. But I mean, people were they were chatty. They were very engaged in telling what they thought ought to be done. But the big thing was, we're here too. We're people. We are part of North Carolina, and we need to be paid attention to. So, Bill, add your comments on things.
Well, I mean, what I was hearing was a lot about lack of real educational opportunities, and those educational opportunities started with the public schools. It was teacher pay. It was also low expectations for student performance, particularly among minority groups and Hispanics. It was lack of real job opportunities. So the community colleges are having to track folks into lower end positions because other positions just simply aren't there. There were issues of concerns about safety. The transportation was a huge issue. Uh, we got into in the group I was in, they got into a long discussion about public lighting. That in rural parts of the state, the 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 roads are dark and the and hard to navigate, and that causes a real problem as well. But it is kind of lack of infrastructure is what they were talking about uh, in my group.
And they were also really mad for not having a state budget.
Yeah.
they,
Oh,
they didn't hold back on that.
right. And Medicaid expansion. There
Yeah.
were a bunch of folks who talked about that this is the first time that they've really had any health insurance, and that benefit was extended through the expansion, and they were really worried about what would happen if that went away.
So there'll be 3 more sessions. There's going to be one in the Asheville area, one in the Triad area, and one in the Charlotte area. So encourage you guys to check them out if you can when they come up, and encourage people that you work with, like local providers and others, if you happen to be a membership organization, to attend. It is important that I think people's voices be heard. Just
The other
changing
thing I
it.
would
Oh,
add,
go ahead.
well, I was just going to add one more thing because it kind of surprised me, but there were several references to aging-related
Yes,
issues.
there were.
Uh, and I don't know why I went into that not expecting that, but they were there, and it wasn't Mary and me.
Yeah. Somebody suggested that there be a resource bus that goes around to all the areas of a county to share information with people about what's out there and how they can access it. So I thought that was an interesting recommendation. On the legislative front, the one big issue that the coalition and ARP and some other aging groups are tracking right now is that a property tax. There is that. The House has established this committee on property tax reduction and reform. And, we were optimistic when we went into this meeting, these meetings starting, that there might be an opportunity to look at, let's try to do things like expand the homestead property tax exemption or the circuit breaker program so that more older adults and persons with disabilities who have difficulty aging in place because of increased property taxes can benefit from this program. this has quickly turned into a real political hot potato, this whole committee. You've got a lot of people on the committee who are very interested in, they don't like property taxes. And they would like not to have property taxes. And they would like, if we do have property taxes, they'd like to do things like have a levy where, you can't increase property taxes more than inflation rate unless the voters approve it. So groups like the County Commissioners Association, the North Carolina League of Municipalities, they are really, really, their radar is up because, property tax is the biggest revenue source local governments have to do things with. So it's gonna be interesting to see. I've heard there might be some recommendations coming out of the committee for the short legislative session. It will be interesting to see because there's a very divergent views on that committee about what might need to be done. One of the things the committee has also done is they are beginning to look at what exemptions to property tax exist already. Two things they have particularly zeroed in on. One has to do with this exemption that groups that do housing, they can get a lot of exemptions if they do low income housing. And there's a provision that about ownership of who is developing properties and things like that. So right now, there's a lot going on where nonprofits are partnering with private developers and others that are private agencies, and the ownership of things is only like a very small percentage, maybe even 1% by the nonprofit. And there's concern that all these groups that are in it for the money are getting a lot of return on their investment for something that should be nonprofit. The other area that they looked at last month, or the last meeting, was the tax exempt status of hospitals and healthcare facilities of any type. And they, I would not be surprised if there isn't some legislation to make some changes in the current exemptions that do exist out there. But the optimism that we had that we might be able to do something on for help benefit older adults and persons with disabilities in general on those benefit programs, we are so optimistic right now.
Mary,
Unfortunately,
can I just make a comment on that? I just wanted to let the members know that in the newsletter there is going to be an article about that with links to some of the presentations that have been made to that committee. And it's just good information just for an individual taxpayer, but also just to understand what the committee is looking at and how the taxes do affect the area where we all live, and what they're looking at. So I would encourage you to kind of link to that and also look at the committee pages that have all of because everything that's presented in the committees is on the General Assembly website under the committee headings.
Yeah, thanks, Sandra. The next meeting of that committee is going to be on March 18th. The Senate also has formed a study group made up of the Senate Republican caucus members that is reporting directly to Senator Berger relative to what they think ought to be done on property taxes. So I expect there's going to be a lot of discussion regarding this. Members of the legislatures who've been on town councils or county commissions I think they do not want to see wholesale changes in what's being done. I don't believe most of them. So we'll see what's going to happen. The General Assembly is coming back in for the long session, for the short session, the end of April. The thought is it's probably going to be a very, very short session, I think, as we've discussed before this meeting, because it is, election year. We probably will have some type of agent advocacy day. We're still trying to get a little bit of better handle about what's going on, and we'll know a little bit more after the election on Tuesday. But it might take a different flavor. Like, are there going to be issues that we're really going to push or not? It's going to be hard to push anything in a short session. I don't believe we'll take up anything new. But could we use this as an opportunity to help educate about issues or things that we want to promote in the long session, or that we want to make sure that like say if they want to do something on property taxes, our position is known on that. Anyway, so I've rambled a good bit. Any questions regarding anything Sandra or I have said? Okay, Sandra, you'll see any hands? Okay, okay. Thank you all for your attention to that. So I want to change gears a little bit. We've had a very active health equity committee, and thanks to the leadership for that with Daryl and Rosalie, and who they'll introduce themselves a little bit more when they do their presentation. They have done a great job these last year or so in leading that up. But the committee has decided to change directions a little bit. So I'm going to call on Daryl and Rosalie right now to talk about what's next for this committee and some of the exciting things they've got planned. So, ladies, I'm going to turn it over to y'all.
Okay. Thank you, Mary, and good morning, everyone. I'm going to share my screen. Is that okay, Sandra?
Hold on just a minute and let me
Okay.
let you do that.
All right.
I think you can see if you can do that now.
Okay. Oh, I have to send you a request.
Oh, there we go.
Okay. Yes. Rosalie and I are so happy to come before you this morning to share what we have, where we're going and where we're looking at going for the next couple of years, particularly around the fact that health equity has been a hot topic over the last year, and changes certainly have not, escaped us. So let me see if I can get this PowerPoint up.
Looks like it's coming.
And is
There
it
you go.
coming? You've got it? Okay, you can
Yeah,
see it. I'm gonna put it
just
on.
enlarge it. Yeah.
Yeah, I'm gonna put it on slideshow. Let's see from the beginning. All right. So here we go. Can you all see that? Okay, wonderful. All right, so we're going to move through quickly. Rosalie and I have been co-chairing the Health Equity Committee over the last couple of years, I believe. And it's been a great adventure for us. And so today we're going to share where we're going and what we're looking forward to. So Rosalie, take it away.
Thanks, Daryl. Thanks, Mary. First, I just want to thank everyone who has been serving on the Health Equity Committee, as also along with the subcommittees that we have been established, as Daryl said, for a few years now. The co-chairs of those subcommittees, which is our LGBTQ plus work group, BIPOC work group, and the rural work group, got together, and we felt like it was time to do a restructure based on a lot of the current situations going on right now at the federal level, among other things. And so our restructure, it was helping us, one, so we wouldn't be so siloed and that we could all work together, because a lot of the things each of the work groups were working on did have crossover and connection. So that also would be helpful to folks to be working together and eliminate the silo. And along with that, it also helps us to know what everyone is doing and is more time efficient as well, because we do want to respect the fact that everybody is volunteering their time for this. And so we wanted to find a way for folks to be able to have meaningful work and less time meeting. So I'm going to ask for the next slide, please.
Here we go.
So you all see, as our purpose of the restructure really was to streamline operations with integrated structure, and then prioritizing our health equity issues, and then expand capacity for timely information and sharing with partner groups. And in between, Daryl is going to kind of cover what the restructure itself is going to look like, but in between the times that we may not have some of our opportunities for the restructure, the folks who are still kind of serving as the co-chairs will be working to make sure that we are doing our research and updating information timely on the website for the coalition, so people can be able to find timely resources and those manners around the health equity issues. Next slide.
All right. So some of the key components of the new structure are unifying the committee model by rotating thematic priorities for agility. And we want to have targeted leadership roles. So we want leads for content, for outreach, and for training. And by moving into the one committee structure, we'll be able to do that more efficiently and more effectively. And we also want to have flexible task teams formed as needed for specific deliverables, such as advocacy and policy considerations. Some of the core activities and implementation that we are looking at, along with timelines, are developing a health equity speaker series, an online resource hub, and quarterly hot topic conversations, and training and capacity building. So we're hoping to start the speaking series on March 13th, and we'll give you more information about that. So Sandra, I should have some information that we can put in the newsletter and publish that. But look forward to that because this will kick off our speaker series. And then we are planning, so March 13th is that date. May 8th, we're planning on starting the hot topic conversations. And one of our co-leads for the BIPOC work group, Lindsay Golden, will be presenting that. And we're starting off with information around Alzheimer's. My voice is bad this morning. I apologize. Alzheimer's and caregiving. So you'll hear more about that as we develop that. But we're looking forward to doing things like this, and hopefully it will increase the interest, and we'll give you dates well in advance. We're going to do these on a quarterly basis, and that way hopefully you'll be able to attend and learn from what we're doing. We're excited about this because Hot Topics is one of if anybody watches The View, they do that all the time, and it's so interesting. So we thought we'd do this rather than maybe fireside chats, but we want people to get involved. And we have to keep our health equity topics on everyone's radar, because regardless of what happens with DEI or with whatever happens with the federal government, people will need services. And so the issues are not going away. Even if the services go away, we need to make sure that there's a good understanding around what's happening with health equity. The timeline is phase 1. We're going to transition for the first 2 months, and then we'll share with NCCOA and invite others to join. If you would like to join us in this effort, just reach out to Rosalie and myself, and we can put our emails in the chat. And we'll be happy to add you to our list. Phase 2, we'll work on more infrastructure and get the website ready. The resources will land on the website. And so we're working with Sandra on that. And so that should be coming soon. And you just heard about the first hot topic and the speakers. And phase 4, we want to make sure we always are cognizant about ongoing improvement. So, Rosalie?
Thank you, Daryl. As Daryl said, our first hot topic is going to start on May the 8th, and our very own Lindsay Golding with the Alzheimer's Association is going to be discussing caregiving at Alzheimer's. And then Mary Stover Williams, as you all know, has been very hard at work on the smoking cessation for seniors in our BIPOC group. So that was a topic we felt like was a cross section as well. And then our LGBTQ training with Katie and her group has been very active as well. And so this was another crossover topic. Housing policy is a big intersection of topics, particularly when we talk about the work that we're doing around affordable housing, and when we are just even hitting on the property tax issues as well. So, and then the rural transformation will be a big piece that is hoping to address our health worker shortages, which was the work the rural work group started doing a couple of years ago. And then we had crossover with some of the other topics. And then aligned with the DHHS Office of Minority Health, with speakers. We are hoping that we will be able to have them speak in March at our March presentation. So hopefully that will be who we have in March. Next slide, please. And then obviously expected outcomes and measures. We're hoping that this will bring some cohesion and efficiency to the committee structure, as well as time efficiency and increased access to equity-focused resources based on the information we're hoping to keep updated on the website. Stronger statewide collaboration with amongst the folks on the Health Equity Committee and even with the coalition. Enhanced capacity to serve our marginalized older adults. Then having our regularly scheduled where we can do bi-monthly quarterly offerings. And we're hoping that we'll be able to do two sets of offerings. So one will be March, April, May, and then we'll do a focus towards the beginning of August, maybe September, to hit up September, October, and November. And then again, always just having greater visibility for the coalition in these health equity efforts.
Right. So the proposed metrics, because we always have to evaluate if we're going to continuously improve on what we're doing and making sure that the information is available to people. So we have thought about a number of ways to capture what we are doing. So one is trainings and offerings, the website analytics, how many people go to it, how many resources we place on those on the website, attendance at these events. We could do some survey feedback, so immediate follow-up after a presentation, either with a speaker or a hot topic, and others as we continue to develop. So I wanted to share with you the members of the Health Equity Committee thus far, and many of these folks have been working with us for several years. So I want to thank specifically Mary Williams Stover and Lindsay Golden. They have been heading up the BIPOC work group. Dalton Bailey and Rosalie Calarco have been heading up the rural work group. So thank you a lot for all of the work that you've done toward that. Mary Bethel and Sandra, of course, have been our support and as needed, and they have been able to share with us some of the things that are needed and how we can get information out. Katie Kutcher and Heather Carter have headed up the LGBTQ plus committee, and so we want to thank them for doing that as well. And we brought on we've connected with the Office of Minority Health, Sandra Leathers. I believe Sandy may be on the call today, and Danita Nash. And so we thank you for joining us. And then, of course, Rosalie and myself, we've been co-chairing. So if you're interested in joining us, this is a dynamite committee. I mean, we've worked through all of this, and everybody has just done their part. So we're at questions. And of course, we want to thank you. So if you have any questions, we can take those now. Let me see what I have for my last slide I don't have anything. All right. So I can stop sharing so we can see.
So you
Any
guys,
questions?
the information that's going to be virtual will be on the Division of Agents website. I'm sorry, not Division of Agents, Coalition of Agents website. Going back to one of my former employers, sorry.
Yeah.
Yeah.
I was going to say, oh wow, we've gone that far
I'm sure the
already.
Division of Agents would have been a surprise too.
Yeah. But you know
Yeah.
what? Yes, it would have been. I'd like to take the opportunity to say if you have some great articles that center around health equity, send those to us. And maybe we can post it because we want to be a resource to our agencies that are involved with NCCOA and others who might be interested in this work because things are changing as we speak. So if you do have anything you'd like to share, we will be more than happy to look at that and see if we could place it on our website. And if you would like to, and I'm just going to say this, Mary and Sandra, you correct me, but if people find things that are interesting or that they need to post on their own websites, on their individual websites, can they do that as well? Once we get ours up, can they share?
Oh, sure.
Yeah, I would say
Yeah.
so.
Great.
Yeah.
All right.
Yeah, I would
So,
say also on our website, we'll probably be linking to what other websites have too,
Mhm.
because it's no use
okay.
of recreating you know, when somebody has a great resource. Like I'm thinking like disability rights, you guys
Yeah,
probably have a lot of information that would be really helpful for folks to know, so we could link to your website.
right, exactly.
I think that was some of the
Exactly.
discussions is to think of the coalition's website as a curator of all the different information that's out there and kind of a place that people can go to find resources on these different topics. With the speaker series, we'll kind of be creating some of our own resources there, but a lot of it is just finding out what the field is doing and what is good information both in the state and nationally that we can then share on this resource page.
Right, exactly. Any
Questions for Daryl or Rosalie?
or comments? We could take all of it.
And many of you probably have information already, as I said, on your websites or things that you know about. So please funnel information to them to help. And I see Rebecca's already put in a
Yeah,
resource. So thank you, Rebecca, for that.
right. And Sandy, you're new to the group. Did you want to say anything? I see that you had your video on.
No, I just opened the window so everybody could see my face and get familiar with as this is only my second meeting, and I think we just had the first health equity meeting last week. So just
Yeah.
open on the camera and just making sure everyone is can
Tell,
see
tell everybody who
us.
you are, Sandra, and what Office of
Yeah,
Minority Health does.
Yeah.
right. What it is.
Oh,
Yes.
sure. Sure, sure. So Office of Minority Health Disparities, we are the office that is responsible for reporting on um, communities at risk or marginalized communities or historically marginalized communities. And the quickest way I can explain it is that we do everything that everyone else in the Division of Public Health or HHS does or Health and Human Services does, but we do it intentionally for Black, brown, yellow, red, indigenous, disabled, aging, queer, and other marginalized or at-risk communities. So with that intention in mind is how we go about our work. Our cornerstone contribution to the agency is the Health Disparities Report. The Health Disparities Report is a report card style reporting that our office provides. It's a statewide summary of how marginalized communities are doing as it relates to chronic disease and other topics in comparison to their white counterparts or their peers basically. And we put this report out just about every 5 years. The last report from 2014 is available now on our website. And there's also supplementary information also available on the website. I'll drop the link in the chat for all interested parties. So there are community highlighted content. We have information about rural communities, African American, Indigenous, or American Indian, and AAPI communities available now. There's also an overview slide deck, and we'll probably present from that slide deck with some additional additions made for your staff, well, for this space on the 13th when we present. So you'll hear more about the disparities of your state.
Mommy, I want cookie rings.
Okay, just a second, sweetheart. We will share about those disparities on our meeting on the 13th. And you'll hear that as well as some more information about health equity in general and the things that the state or our office offers for assistance. So ready to have that conversation. Looking forward to that.
That is awesome. Thank you. We're looking forward to this relationship. And Sandy, I did send you a private chat, so if you could look at that. All right. Thank you so much, Mary and Sandra, for this time. Thank you, Rosalie, and all the committee members. And we're looking forward to working more, I don't know, together this year on and addressing health equity, health disparities, and I think we're on our way to really making this or making the work that we're doing more meaningful and meeting the goals of NCCOA. So thank you so very much. And again, I apologize for my voice. I don't know what happened, but it's not
You're
easy to
good. You're
talk.
good. And thank all of you for all you've done. I mean,
Yeah.
you've done a lot of work, and I'm really excited about what's
Yeah.
the new direction and what you're proposing to do. So that sounds
Yes,
good. And
thank you.
something's coming up already. And the decision,
Yes.
the talk was, should we do something in conjunction with the Coalition on Aging meeting, or should these be freestanding, presentations or sessions? And the
Yeah.
decision was made to go with freestanding sessions. So be on the
Yes.
lookout for the announcements about things coming up. And
Right.
Sandy,
March 13th
yeah, and Sandy, don't
and
worry
May
about that
8th.
interruption. We all have them, and now you've just put the idea of cookies is now in all of our brains now. So
It never stops. I appreciate it. I appreciate that. Thank you so
no
much.
problem at all.
Working
Thank you,
moms, we're a
everyone.
minority too, in a way. Yeah,
Yeah, exactly,
in a
exactly.
way. Thanks, everyone.
All right.
Thank
Thank
you.
you.
Okay, thank
All
you,
right.
guys. Moving
All
forward
right.
on the agenda, we're going to have Sharon, the coalition members. And Tara, I saw your name. You put something in the chat. Why don't you share about that to start us off?
Hi, everyone. This is Tara Muller from Disability Rights North Carolina. Yes, we have just reached a settlement associated with some nursing homes that were kind of engaging in a process where they kind of had a blanket policy to exclude people who had a history of substance use disorder or who were currently using substances. And so they just had a blanket prohibition on people with those conditions. And we reached a settlement with those nursing homes. It was Sunnybrook and Treyburn and their chains to, we reached a monetary settlement, but also a non-discrimination settlement where they have agreed to, going forward, create policies that allow them to assess each case individually. So if somebody has a history of substance use disorder or even have an active substance use disorder and are receiving things like outpatient treatment for that, like at a methadone clinic or something, those cases have to be evaluated individually. So we were really pleased with that settlement, and we think it'll help a lot of people who are having a hard time finding placement in a nursing home. We also hope that this information will spread across the state to other facilities so that other facilities will voluntarily adopt those same policies.
Okay, thanks for sharing that. So this is brand new, just
No,
settled.
it was late last year. So
Okay, great. Well, thanks for updating us about it, though.
Mary, can I also just remind everybody, if you have not put your name and organization, if you're familiar with it, in the chat, please do that. That just kind of helps us understand who our members are and attending each of the meetings. I appreciate that.
Thanks, Sandra. Okay, I know there are a lot of training sessions and conferences and events coming up. Anybody want to plug something you got going on?
Mary, it's Rebecca.
Uh-huh.
Well, next week is kind of an exciting week for anybody who graduated from the Ann Johnson Institute. On Wednesday next week, there will be kind of a celebration of 25 years of the Ann Johnson Institute. And so we've opened up the invitation to that to lots of people to come. I think you're going to be there, right?
No, I can't go. I've got another thing that I'm doing that evening for another presentation I'm doing. So
Okay.
sorry, I'd love to.
Gotcha. So that's next week. And then Teresa's on here. She's been working really hard to support Glenda and Terry and Lori and the team planning the Adult Day Services Conference. And we have met our attendance goal, so I'm super relieved. We have about 165 people registered. That'll be on March 24th and 25th. And if anybody's still interested and needs the registration link, I can put my contact in the chat and share that.
So Rebecca, that's going to be in Winston-Salem, I believe, isn't it? The
Yes.
Adult Day Services Conference. Okay.
Yes.
The Ann Johnson Institute, is that just a one-day event, or is that going to be a training session also?
So the Ann Johnson Institute for Senior Center Management is always 2.5 days for the modules, and that's for people who are currently working in senior centers only. But the celebration event is Wednesday evening.
Okay, gotcha. All righty. All right. Anybody else want to plug anything you've got going on? Is registration still open for the Legacy program at UNC, or is that closed now? I saw somebody from there. So, she must have stepped off. You might be interested in checking that out. The UNC Legacy series is next week. It's focused on aging. It is free, and they have an online virtual option, so you don't have to go to Chapel Hill to the Friday Center to participate in it. So that would be something that you could take advantage of if you were so inclined to do that. Sandra, you see anybody else in the chat that's got anything going on they want to mention?
No, not right offhand.
Okay, let me just see. I'm just looking to see if I see anybody that I know has got anything. Are any of you planning advocacy days for while the General Assembly's in? Or is everybody waiting to see what happens? I don't think we have anybody from Social Security on today.
No.
And I see Gina Upchurch. Gina, do you want to explain about the federal committee you're on and what you guys are doing right now?
I am happy to, but you don't want to see me because I'm still in my pajamas. Came back from Botswana and still a little GI issues. But anyway, yes. So I am on commission and in my third year of something called the MedPAC, Medicare Payment Advisory Commission. And we meet 8 times a year in Washington. So I'm cramming my reading because I go Sunday. We have a meeting Monday and Tuesday. And so, when I'm speaking about MedPAC stuff, I'm just speaking for myself, not the full MedPAC, obviously, Medicare Payment Advisory Commission. But we basically create 2 major reports a year. One comes out in March, so will be published soon, about payment reform, how much we pay for 8 different services, including home health, hospice, hospitals, physician fee schedule, so on and so forth. The more interesting creative piece comes out in June, and we're working on that now. And that's where we have different streams of work around Medicare policy. We're looking at post-acute care, whether somebody goes to a skilled nursing facility, a rehab facility, or gets home health. How do we look at those things across a continuum of care? I'm very interested and have been driving some of the discussion around consumer choice and how it's way too complicated for people and leads to decisions that people don't necessarily understand. So trying to work on that. Our meeting this coming Monday and Tuesday, because it's public knowledge already, will have some things to do with consumer choice. So I've been busy getting ready for that meeting. And in our next meeting, which has never happened before, the MedPAC will be discussing the influence of brokers and agents and SHIPs on Medicare choice decisions. We create these reports. There's a staff of about 35 people with the MedPAC, and they work closely with CMS, but our work is to advise Congress. So the information really goes to their staff. Many of the things that we recommend eventually get picked up, but they're not immediate, but they end up becoming policy most often over time. We don't meet with members of Congress. Some of the chair and vice chair maybe meet with members of Congress, but we mainly write these reports working with our staff to go to the staff of congressional members. But of course, we write lots of comment letters about CMS. So I'm very proud to be on it. There's 17 of us. I guess the big news is that the Comptroller General of the Government Accountability Office is who appoints us. And that person resigned after 15 years, Jean Dadereau. And I filled somebody's term for 1 year, and then I got my own full term. So I'm in the second year of my full term. And so they'll potentially be another full term, but there's going to be a new comptroller. So I'm not sure, next year how that will go for me being reappointed. But I've been super happy to serve, lots of smart people, and we work on federal policies, but we also have to stay in our own wheelhouse. One of the things I've been sort of pushing and trying to push too is this conversation of how we link people with Medicaid and Medicare, so people who are dually eligible for either full Medicaid or partial Medicaid, Medicare savings programs, and more integrated care. It's something that's also on our radar, but we don't do a great job. We sort of stay in the Medicare silo. The MACPAC, Medicaid Payment Advisory, stays in the Medicaid silo, and we don't, in my opinion, work together as closely as we should and need to. So we're sort of pushing that envelope a little bit. But anyway, thanks for asking, Mary.
So I know that there's been a lot of, a lot of attention about changing some of the advisory committees and things like that, and policy committees that are in existence at the federal level. Is the MedPAC subject to, having any disruptions in its operations as far as you know?
Great question. We're part of the congressional branch of government. So I am a special government employee, quote unquote, just like Elon Musk was, but for the congressional side, not the executive side. So there has been less tampering with the congressional side of federal government. Having said that, we're getting a new comptroller, and the comptroller of the Government Accountability Office is who appoints us. They appoint the commissioners, and decide who's chair. And they also, the GAO not only appoints these commissioners, but they also have oversight of the Congressional Budget Office. So on the executive side, you have Office of Budget and Management, and that's very pressured by the executive, wing. But on the congressional branch, you have the Congressional Budget Office, which often has very different take on things than the executive branch. So the congressional branch of government has been less touched by many of the things. But because there's going to be a new comptroller, Congress gets to put forward 3 names, the president gets to decide who the person is, then reappointment. So it's a 15-year term.
Wow.
So it's a big deal. It's a big deal, and people are very anxious, as you can imagine, about how this is going to roll out. I'll be honest. I think, the beauty of the work we've been doing has been not partisan. I mean, I keep saying, I don't know a Democratic hospital or a Republican hospice. I mean, it's like public policy, it's health policy. And so it really should not be jerked around by politics. And it hasn't been up until now that I can really see. But it is becoming, people are writing in about sometimes commissioners, sometimes, and trying to politicize it. But I really, being on the commission, have not felt that, like in the work that we do. But I think, things are changing. And so, the antennas are up. And so we'll see if it stays, basically solid public policy, health policy, or if it becomes divisive, frankly. But so far, I'm knocking on wood. It's been the leadership, the staff is fantastic, and they have long-term relationships with members of Congress and members of CMS. And I don't know for those of you who've heard, but Center for Medicare and Medicaid Services, yes, they've had leadership changes at the top with Dr. Oz and the people that he selected to run it. But frankly, a lot of the people who do the day-to-day work at CMS have remained. And they work very closely with folks at the MedPAC and the MACPAC, and that's gone on as usual. So it's not really been touched because, again, we're more on the congressional branch. So TBD. I'll keep you posted. Thanks for asking.
And fingers crossed, right, that it stays that way.
Yeah, absolutely. Absolutely.
Well,
Thanks.
Yeah, appreciate it. And thank you for sharing on that. I see also that, Rosalie, you put in the final program for the UNC School of Social Work Legacy series too. So y'all might want to check that out. And then Martha Fowler also put in that the State Employees Association of North Carolina is having their lobby day on May 6th. So
I
go
just
ahead,
wanted
Martha.
to say, Mary, I wanted to talk about our lobby day. The State Employees Association of North Carolina, we're inviting all active and retired employees of the state of North Carolina to attend our lobby day. We too are very disappointed that there is no state budget, and it's affecting lap salaries, and all agencies are having to deal with the lack of a state budget. So I just wanted to emphasize that you can mark your calendars now for May 6th, and we're hoping that we'll have people from the East, West, Central, Piedmont, North, and South of North Carolina to attend our lobby day.
Very good. Thank you, Martha. Appreciate
You're welcome.
you sharing that. Martha's a former board member, so thank you for your service to the coalition also, Martha, over the years.
You're welcome.
Okay. One last call. Anybody else got anything you want to share? Okay, I believe Kelly is here. Sandra, I haven't looked at my participant list yet, but I think she may be.
If she is, speak up. I don't see her name on our participant list yet.
She knew it was 11:15, so she'll probably be here any minute if she's not. Let's see. I tell you what, Sandra, if you want to sing, I'm going to contact her to sing.
Wow. Mary had a little lamb, little lamb, little lamb. Mary had a little lamb whose fleece was white as snow. How's that? I think we just lost about 10 on the botnet. That's about as risky behavior as you'll get from me. So, you know, I'm always up for doing things like that. Singing and hats on my head. I don't know why. Too much information for y'all, but I do want to say, and seriously, I celebrated my 1-year anniversary with the coalition on February 3rd. And it is amazing to me the depth and breadth and width of knowledge that thank you all. Appreciate all those thank yous. I didn't say it for that, but it just amazes me that the knowledge that this group has, and to the levels such as the national level that we and you advocate for issues related to older adults, and the voices that we bring forth that help with policy issues, that advocate for needs of older adults in whatever stage of life that they are in. I really am in awe of what this group can accomplish and has accomplished just with the backgrounds that we have, and continue to push as if anybody can push the envelope, Gina, I know it's you too, just to try to make that sense and the information that is out there equally across the board, to make sure that people know what they are eligible for, what they can do in regards to their own health, in regards to their own life. They don't have, you know, as older adults, you don't have to be completely satisfied with, or you don't have to take the situation as it is, I guess is what I'm trying to say, that there really are ways in which we can educate and advocate for folks out there. So I just wanted to say kudos to this group and send you all of those celebration things that you just sent out, because it really is a good group and it's been fun. And I'm looking forward to the role that I'm going to transition to in the operations part, because I think the member relations part, I will get to know you even more. So thank you for that. And I see Kelly on the line now.
Okay.
And Mary, if you want to introduce Kelly.
I will be glad to, yes. Hey, Kelly, good to see you. Thank you for joining us. And do you want to pull up your slide deck? You want Sandra to pull it up for you? Whatever's good for you guys.
I'm happy to do it. I can try. Let me see. Let me see if I can make it work. Me and
Okay,
Zoom
while
are
you're
the
doing-
best of friends.
Yeah, let me introduce you while
right,
y'all are doing that. Okay, we're glad today to have Kelly Crosbie. Kelly is the director of the Division of Mental Health, Developmental Disabilities, and Substance Use Services. And she has been for a couple of years here, but she's had a 30-year career of working in the field. Anybody who's been around in human services in North Carolina knows her. She is known as a hard worker. She's known as somebody that's great to work with, and I don't know if many of you get the newsletters or on the email list for the department or not, but she sends out the best information about what's going on in health and human services in North Carolina. And she's been incredibly busy this last year. They were able to the division was able to get some additional support funding, and they've done some very creative and innovative things to expand mental health and substance use services across the state. She, an honor for her, last year she was selected as the Social Worker of the Year by NASW North Carolina. So we're congratulate you on that. Much deserved, that's for sure. But I'll turn it over to you. Just you can say anything else you want to say about yourself. But she's going to talk today about what's going on with public health and public mental health and substance use services for older adults, and then some of the broader things that they've got going on as a agency. So Kelly, thank you for joining us. I know your time is really busy. You had to, I guess you were doing a video recording this morning of something. So thank you.
No, I'm delighted to be here. I really appreciate it. Mary, thank you for saying all those kind words. So, and I know many of you on this call, some of you I might be meeting for the first time, but it's a real privilege to be here. And my name is Kelly Crosbie. I think there's a slide that introduces me a little bit more, just so you can see it. I have been around for a very long time. I've been at the department for a long time. I'm closing in on 15 years. I spent a long time at the state Medicaid agency, actually many years at the state Medicaid agency, over 10 years there. I've always been a social worker though, and even when I was at Medicaid, I did my work in the social work field. I have worked with folks with mental health, intellectual and developmental disabilities, and substance use services in so many different ways. As a clinician, at the meso level, at the macro level, and it's a real privilege. I am a person with lived experience. So I was raised by a dad with serious mental health issues. I've got family members with serious mental health issues, substance use disorders, justice involvement, and developmental disabilities, because I am just like everyone else. And that's actually pretty darn typical. I have been in this role for 3 years, and I would say I had the privilege very early on in my tenure of doing a PBS special with Joyce, and I think it was Rebecca. No, might not. Rebecca, it wasn't you, but
I was there, but I wasn't on the special.
Okay. I had the privilege of talking about ways that we are identifying and addressing mental health needs in particular in older adults. And it was a lovely show, don't get me wrong, but the loveliest part was the hour we had in the green room before, just getting to know one another. And it was just the most wonderful opportunity for me to listen and learn from Joyce about her concerns and what you all have been working on collaboratively with older adults. And I have to say, I was incredibly inspired. And so again, that was right at the beginning of my tenure here. And I wanted to know right away what we were doing to support older adults with our service array in the public system. And we've been trying to strengthen what we do ever since. But I'll tell you a little bit more about kind of what some of our goals were for this year, where we've landed on those goals, and we are always want to hear feedback about what more we can do. But before that, as Mary said, there's a lot going on here. And I actually think like one of the ways I feel that we do a disservice to older adults is we don't think about you in everything that we're doing. So I want to tell you super quickly, I promise it'll be quick, kind of like an overview of everything that we're doing, because I want to be purposeful and mindful, and I want you to know, because in everything that we're focused on, there are older adults who are affected by, or could be positively affected by some of those initiatives. I think I'm with the Division of Mental Health, Intellectual and Developmental Disabilities, and Substance Use Services. I think folks know what that is by and large. It is our job to develop policy for the state. It's our job to have the state plan, the public plan for mental health substance use IDD. So that really is inclusive of all federal and state dollars we get for the public system. It's inclusive of Medicaid. I don't run the Medicaid program. I don't pretend that I run the Medicaid program, but we get to influence the Medicaid program because they are the largest payer in the public space. And it's our job to say, from a policy perspective, how do we understand and tackle some of the biggest problems in our system in the state? How do we work with the legislature? How do we get funds? How do we work at the federal level to get funds? How are we measuring access and success here in our system? We do administer a lot of state and federal dollars, lots of them. And on occasion, we provide statewide supports. Like we fund and we don't run, but we run through a vendor like the 988 program, for example. So what I wanted to tell you a little bit about is, again, by law, we're actually required to have a state plan for mental health, substance use, IDD, and traumatic brain injury. And so we spent, my second year here, we spent a lot of time going around the state, listening, talking, learning, looking at the data we had, looking at our programs to try to identify some of the biggest priorities here in our system. And we created our state plan, again, that we're required to have. It is published. We did a lot of listening sessions. It lays out our mission and vision, our commitment, who our priority populations are. It lays out our goals, all of the activities that we spend our time on, and our money. I always tell people that, like, the plan is us being really transparent about what you have told us are some of the biggest issues, what you've told us some of your goals are in the public system. And I'm telling you, with this plan, everything that our staff is working on and how we're using our money. But the whole goal of everything that we do, is to make sure that we are creating a North Carolina or supporting a North Carolina where everyone lives a happy and healthy life. That's why we do everything that we do. It's not to decrease symptoms. It's to make sure that people are living happy and healthy lives. We believe in a wellness recovery-based system. Okay, so here are the 7 things we're working on before I dive a little bit deeper into our priority work on for older adults. Our first priority, and you'll see a big star there, a lot of our work with older adults is centered in our first priority, which is about increasing access to care around the state. Obviously, it's our first goal. It's a really big one. And we do a variety of interventions in that space. And we want everything from access to kind of classic clinical care. More people need to be able to access therapy. I'll just say it in the most basic of way, therapy across the state. And when they do access it, we would like them to stay and find it beneficial and move into recovery, whatever that's for, substance use, mental health services. This goal helps us focus on where people get access. They often get access in primary care, so we had a huge focus on beefing up access to mental health care in primary care. We know that is a place where older adults seek care and may feel most comfortable seeking mental health or substance use care, far more than they might feel comfortable walking into a mental health clinic. We've also focused on alternative access to care. Not everyone is going to go to a mental health clinic or even a primary care office. So some of the things I'm going to tell you about that we funded was trying to increase access in different ways. What are places and spaces that older adults, for example, go to? We have other priority populations too, right? Veterans are a priority population for us. They may go to different spaces and places where they may talk to a veteran rather than myself or go to a therapist's office for care. So with that priority, we acknowledge that we need to make sure that we have places, or we're addressing places and spaces where older adults feel comfortable going. So hold that thought. We also wanted to honor caregivers, and I think this is really important in the older adult space. So remember, if someone is in clinical care, meaning they're going to therapy, whatever it is, we have to just accept the fact that that's like an hour, 2 hours a week, maybe at most, with active clinical care. Active, right? Not everyone's in active clinical care. You don't need to be. Anxiety and depression, you manage it like you manage diabetes every day. So that means where are people? They're living, they're working, they're with their families. And depending on the level of severity of need that a person has, their caregiver might have a lot of pressure and strain to be providing them supports, whether that person has an intellectual disability, a substance use disorder, they're in recovery from a hospitalization for mental health issues, whatever it is. They're with their caregivers a lot of times. And so their caregivers need as much support as possible. So we put some dedicated, and we will continue to put dedicated supports out for caregivers. We want to make sure that they are okay. Healthier caregivers help people have healthier lives. And so this is all in pursuit of that goal of helping people be healthy and happy. Okay, I will not spend as much time in the other things. Priority 2, we've done lots of work to make sure that people with intellectual and developmental disabilities and traumatic brain injury get access to more services. We've made some good progress there. Our third priority, not surprisingly, is we are trying to prevent substance misuse, so hyper-focused on prevention, and overdose. Our overdose rates are actually going down as a state substantially, which is really cool. And we are increasing access to evidence-based treatment. We have a lot of initiatives in that space aimed at preventing stigma and getting people into evidence-based treatment, because there's actually a lot of opposition here in North Carolina to evidence-based treatment. People are highly uncomfortable with things like medications for opioid use disorder, although they are the gold standard and they help people maintain their recovery forever. We don't look at substance use medications like we look at diabetic medication or insulin, but actually they're the same thing. They're maintenance medications. Substance misuse among older adults, we know, is underdiagnosed for lots of reasons. We'll talk about a little bit of those, but that is, again, this is an example of we always need to be thinking about how we're addressing substance misuse or any of these other priorities in older adults. Older adults with intellectual and developmental disabilities have very specific needs, and they have very specific concerns from their caregivers. Priority 4 is building the workforce. We have a variety of initiatives trying to increase the caliber of care provided by our unlicensed staff, but also to bring more licensed staff into the field. You will see some of the grantees we have this year. We did specific grants to agencies that support older adults. You'll see that in a minute, community-based organizations. Something that all 3 have in common is they're actually helping to build a workforce better equipped to recognize, understand, and address mental health and substance use issues in older adults. So that actually featured across all 3 of our grantees. So building the workforce isn't just getting licensed people out there. It's not enough. I'm a clinician. I served as a community clinician for many, many years. I was not knowledgeable and equipped or even trained to deal with the unique needs of older adults. I had to seek additional training so I could know what to do and be good at that. So we would never assume that all of our field is prepared to meet the needs of older adults, and that's why we're getting training out there. Our next priority is strengthening the crisis system. Priority 5 and 6 are huge focuses right now for us, or foci for us. Some of you may have noticed that the governor signed about 2 weeks ago Executive Order 33. It was an executive order aimed at addressing behavioral health and individuals in the justice system. So it was behavioral health and public safety. He has called upon DHHS, as well as the Department of Public Safety and the Department of Adult Corrections, to collaborate on a variety of initiatives aimed at getting people, when they are in crisis, into the crisis system, that it's a robust, meaningful, and working crisis system, that if people are incarcerated, they're getting adequate treatment while they are incarcerated. And when they return to the community, because 90% do, that they're well linked to services, because when we have good mental health and substance use services for people, they do well, they are healthier. And so we want to make sure we have a healthy North Carolina, but we also want to make sure in those rare instances where someone with an untreated mental health issue may have something like a paranoid delusion or have thoughts of harming others, that they are getting effective treatment as early as possible. So we want to make sure that we're addressing public safety as well. Just a sidebar, people with mental health and substance use issues are much more often the victim of crime. They actually perpetuate very few crimes that are often the victim of crime. Just want to point that out. Our last goal is around people with our most complex needs. So these are adults, and you know some of them. We have a unique group of older adults in North Carolina who have lived with a severe mental health issue for many years. Many of them are living in adult care homes. They've never lived on their own. They've always lived at home. They've never had a job. So we have a subset of older adults who, unfortunately, were raised in a treatment system that did not understand the notion of recovery, that believe in institutional care, that assumed a person had a disability for life and would never need a job. And so we actually have a lot of older adults with serious mental illness who unfortunately have a kind of a decades-long, they've been treated for decades as if like, that's it, life is over, you have a disability. And so those adults have very unique needs. So priority 7 is all of our actions focused on older adults with very complex needs, making sure we have enough programs for those adults, but also for the subset of children with our highest needs who often end up in our emergency rooms or in out-of-home placements. We have goals focused and programs focused on those children as well. So that's kind of the big broad system, right? All of the stuff. You should be able to see older adults in all of this. But let's talk about a key accomplishment. I have accomplishments in all of these. We just published our annual report. If you tune into if you get our hot topics, Mary mentioned hot topics, you'll see we just released the report. We talk about the progress we've made in all of these areas. The thing I want to put a star by is one of our accomplishments is actually funding agencies who support older adults, community-based agencies specifically that support older adults. So that is actually one of our key accomplishments, but I'll tell you a little bit more about those in a bit. Okay, so let's talk very specifically about mental health and substance use in older adults. I'm going to quote you some statistics, but you probably know these already, so I will not belabor them, okay? But I want you to know, again, when we think about what services and systems we need to build, we want to base them in fact, right? So here are some facts that you, because you are a well-informed and passionate group, right, you probably know about, right? So as we grow older, there's a heck of a lot of stressors. We know that the kind of stressors older adults face, actually, it is quite normal to have emotional reactions to those, like depression or anxiety. Change in life, change in career, losing your partner or spouse for many, many years, changing where you live, increasing social isolation, losing your friends. Those are all incredible stressors that regardless of who that happened to, if that happened to a 25-year-old, they would also experience anxiety and depression. That's very typical, or they could be at risk for. But we know these are unfortunately typical experiences, or not fortunately, it's the circle of life, right? This is what older adults experience, right? But these are life changes, and we need to acknowledge that they can be, depending on the protective factor of the older adults, they can bring a tremendous amount of stress. And we know stress leads to symptoms of depression, anxiety, and other things. Statistics are just true. And we have to embrace this. I tell this to people all the time. Between 1 in 4 and 1 in 5 adults, aged 55 and older, do deal with depression, anxiety, or dementia. That's very typical. That's actually typical of any population, just to be clear. Statistics for all adults, 21 plus, is actually 1 in 4 have mental health issues, the most common being depression, anxiety. Remember, depression and anxiety don't have to be lifelong. They can be transient and people recover. I just want to point that out. So a lot of older adults also have a substance use disorder. Wildly underdiagnosed a lot of times. We'll talk a little bit more about that in a slide. And a thing that we see persistently, though, despite these statistics, maybe saying 20 to 25% of older adults could potentially benefit from treatment of some kind, right? Because we all could. They don't all get it. Statistics are all over the map, right? But we basically perceive, and in some of the data we have, we know that older adults are way underrepresented in our services. So just very typical things like 988. We get statistics every month on who calls 988. The lowest group of users is over 55, by far, lowest group of users. So those folks are not using 988 at all. I will show you some of our ad campaigns for 988. So a big risk that we need to talk about is that suicide rates among older adults are actually pretty high, especially older adult male. Males over the age of 85 did have the highest rates in the state of death by suicide. Males a little bit younger, 75 to 84, had the second highest rate. And just overall adults age 65 and older have the third highest suicide rate here in North Carolina. And we also know, you know this, again, you're experts. I appreciate I'm speaking to experts here. That is probably an underrepresented number, right? We don't always know that an individual has died by suicide. I don't say that to be startling. I say that because we care very much. Suicide is a huge priority for us here in North Carolina. but it speaks to the need. It speaks to someone who was not getting care early enough. No, it wasn't noticed. They didn't get the help that they received. And sometimes tragically, this happens. So just to be really clear, because this is a weird misconception we deal with. Again, probably not you, but the general public. Depression is not a normal part of aging. Change is, but depression isn't. Mental health is also diagnosable and treatable. We shouldn't just assume, oh, you're older, you're going to be alone, you're going to be depressed, you're going to be anxious. That's a normal part of aging, all good. No, actually. Again, remember our mission and vision. Everyone deserves a happy, healthy life. Everyone. There's not an age cutoff for that. So we shouldn't just accept it. Oh, yes, that's normal. You're going to be depressed and anxious. No, you can be, but you can get treatment for it. And so that's what we should be focused on. Worry and anxiety shows up really differently in older adults. It can show up really differently in everyone. Just to be clear, we just tend to misread it. We see it as grouchiness, irritability. That's also a sign of depression. And sometimes we're just like, oh, that's the cranky older person, right? Said with love, right? But that's silly. That is just biased thinking, right? And that person might be. Maybe they spent their life as a grouchy person and that's their personality. And maybe that's actually a sign that they're not doing well. They're not feeling so well. I myself, when I'm not doing well, my first sign is irritability. That's actually my first sign. That is always my first sign. When I know that, woo, I need a little bit of wellness break myself, it is because of irritability. So that's actually really, really common across all ages. We just tend to misread it in older adults. We just assume, oh, that's them being them. A big place we miss all the time is substance use in older adults. And again, this is an area that I'll just be transparent with you, is particularly sensitive to me. My grandfather, I just loved my grandfather. Wonderful guy, wonderful Italian guy. His parents were immigrants from Italy. He was an amazing guy. He served in the Merchant Marines when he was 16. He lied so he can get in the military, or in the Marines, excuse me. And my whole life, he drank. He just drank all the time. He'd wake up with whiskey coffee and he would drink all day, every day. But he was so charming and friendly. He was a very friendly alcoholic. As long as I'd known my grandfather as well, he was on antidepressants, as long as I've known him. I have never, ever known in all the times, and as he got older, he moved closer to us and my mother became his caretaker. So I was a bit more familiar with his actual medical care at that point. There was never a time that his doctor ever suggested he's drinking too much, ever, just didn't, and was always happy to up his antidepressants. Unfortunately, the experience of my grandfather, I don't think is atypical. In later years, he started to have dementia, which I firmly believe was alcohol-related dementia, but no one ever addressed that. No one ever said, hey, Jim, friend, how much you drink a day? You do realize that's a lot. Your tolerance is extraordinary, my friend, and that might be affecting your mood. And all the Prozac in the world I'm going to give you is not going to counter that depressant that you're drinking by the gallon every day. So we tend to do that. We tend to do that with all ages of adults, but certainly older adults. And there's also sometimes a perception, because we get this a lot of time in the mental health field, there's a lot of perception that this is so classic for us. When we're helping someone with mental health and anxiety, the rule always was, I know you're smoking, but I'm not going to bother with that because you got enough on your plate with anxiety and depression. It's this real common thing. We tend to do that with older adults too, right? Yeah, you're drinking, but that's not your biggest issue right now. You have cardiovascular disease, you have COPD. I need to worry about those things. You have a little bit of dementia. Drinking makes you happy. I'm not going to poke on it right now. The drinking is not helping any of those things. We know that, right? And it's not helping the person not to address it, helping them get the treatment that they need, respecting them enough to point out that their alcohol use is actually probably not working well with their meds, might be exacerbating their chronic health issues or their dementia. That's really the kind and good thing to do. But we still tend to shy away from it. So we also have older adults. And again, we all know them. We do. I've known many of them intimately. I've been related to them. Older adults who use excessive amounts of pain medications or anxiety medications like Xanax, things that are habit forming. We used to have a culture a very long time ago of giving those medications out to adults and older adults with abandon. It's just true. We just did. Some of that has changed a lot with us recognizing the impact of opioids. But again, it's not uncommon to meet women in older years who have been on Xanax for decades because that was the mama's little helper they got from their doctor because they were a nervous lady. Instead of getting true help, right? Putting them on addictive medication. Same thing with pain medications. And so that's not to say that people don't have real anxiety and real pain. Of course they do. Of course they do. So let's provide good treatment for it, not put them on a habit-forming medication. But again, there's just a lot of that. Some of it's very cultural, some of it's the nature of medicine. But even today, these kind of conversations about medications with older adults can be really, really difficult. Okay, there's a lot of barriers to service. I think I mentioned all of these, right? There's not a lot of clinicians that know how to even recognize depression, anxiety, or substance use in older adults. It's easy to write it off as a medical issue. It's easy to write it off as that personality issue, as a sign of aging. But at the same time, older adults, again, when you think about the culture, I will tell you, my grandparents would never have been comfortable going to a mental health provider, and it just never. Doesn't matter what I did for a living. Doesn't matter what I do for a living now. My parents are in their 70s. Doesn't matter what I do. They don't have comfort thinking about mental health and going for mental health treatment, even though my dad has a diagnosed and well-known mental health issue. But remember the culture they come from. They've come up from a culture of, if you have mental illness, you're quote unquote crazy, you're weird, you're dangerous, you're scary. We need to put you in an institution and lock you up. You can't work anymore. That's real. That's not just like an imaginary thing that happened. That was our culture 40, 50 years ago, 30 years ago even. We only began to see real change with the passage of the ADA. We only began to see real change in the 80s and 90s. I mean, this is like, so there's still a lot of deeply seated fears and anxieties about disclosing that you might have mental health issues or a substance use issue, because you do not know how you're going to be treated or perceived or treated. There are a lot of just real life barriers too. So again, when we think about older adults, part of our goal is to think of, again, how can we reduce the stigma? How can we make people comfortable talking about mental health? But how can we just be okay with, right? If I always say my grandma, adored my grandma, right? She was one of those grandmas who was given Xanax her whole life, adult life as a woman. She was just nervous Elda. That's what she was, given Xanax her whole life. She was just a wonderful and lovely human. She had terrible anxiety, but we always called it her nerves. That's just what we called it, because that was her comfort space to call it her nerves, and that was okay. Grandma talked about her nerves. We talked about ways to help grandma's nerves, and that was comfortable. And grandma got her help from her church. That's where she got help, and that's okay. She got her nerve medicines, unfortunately, from her primary care doctor, but that's where she was comfortable talking about her nerves, right? So we need to equip those primary care docs. And she got the support and love she needed to feel better, to feel healthy from her church. So those are just different places and spaces than going to a mental health clinic. We want mental health clinics to be open, welcoming. We don't want people to be afraid, but we have to acknowledge and build up resources in other spaces that older adults might be comfortable. Okay, so let's talk about the goals we had in the division to try to improve the supports we're providing in the public system to older adults. So we have reviewed our current programs, like the HEART program. We'll talk about that. That's a resource we still have. We still have an outstanding question, I'll be honest. What's working and not, and how should that grow and change? We did want to give out more community grants to organizations that support older adults that maybe were less traditional spaces than a mental health clinic. And we absolutely, and we're grateful for this every day, wanted to have more collaboration with our Division of Aging and Adult Services on some of their huge initiatives. When Joyce told me about, and Rebecca told me about the wonderful things happening in the DOS space, I was like, wow, we really want to support that and be a part of that. So I appreciate their leadership and letting us become involved in those things. So what have we done? Y'all know Lisa Womack, I hope. She's on this call right now. So one of the first things that we did is to say, okay, we need a person here that their full-time job is actually focused on older adults. So that's Lisa. And part of what Lisa has been doing in her time here is just increasing community engagement, understanding the landscape of what we do have and don't have, building bridges with organizations like yours, with Aging and Adult Services, because first we need to engage, we need to be trusted, we need to listen and learn where we can do better or where there are gaps or where there are strengths that we can build upon. So that's what Lisa has been doing. She is, yes, working on engagement, but also working on a more comprehensive strategy. She also serves as consultation to all those programs that I mentioned, right? Whether it's the IDD team, whether it's the team working on substance use, Lisa provides consultation to them. And that person saying, hey, but how is this programming supporting older adults? Or hey, how does this need to be modified to support older adults, for example? She is also, and we as an agency are collaborating now with DOS on the All Ages, All Stages. We're big supporters of it. We are sharing some of our HEARTS data with Dementia Capable North Carolina Coalition. And our Suicide Prevention Action Plan has a dedicated section, meaning actions, not just a written thing, but actions for older adults. This is not me saying we have it all covered. This is me saying we have made change. And we want to continue to listen to you, build up, again, continue our engagement, continue our listening, learning, and continue to make change. So let's talk about what we do have now. We have the HEART program, which is a much better name. We changed the name of the GAST program, which was something like, G stood for geriatric. That's all I can tell you. So we do not say that word anymore, all right? The HEART program now is Health Education and Aging Resource Team. Okay, that's the HEART program. So again, remember what the HEART program does. We give funding to each LME, and that LME is responsible for having agencies that train the community by and large. So they can go to nursing homes, they can go to AAAs, they can go to day programs. They can train the staff there on everything from mental health first aid to understand signs and symptoms of mental health and substance use. They can help train clinicians in the field. So if someone does need a referral to a mental health clinician or substance use clinician, that they're prepared and helpful. So it is a free service to communities, but the goal is to increase community capacity to understand and respond to the needs of older adults. And this is one of those things, like, I think some of our HEART programs are stronger than others, to be honest. We hear that feedback from you. And also, so we want to learn how the strong ones are working and how we can do better with the ones that need more. But also, this is an area where we're looking at how we can increase our funding, so to increase the reach of the HEART program. We have, and we're really proud of this because it keeps growing, our Certified Older Adult Peer Support Program. And some of our grantees are using these Certified Older Adult Peers right now. Remember what a peer is? Someone who's been there, walked in those shoes. It's an adult over the age of 55. They have their own experience with mental health needs as an older adult. They have their own experience with treatment, however that looked. And so their job is to help that older adult through their own lived experience walk through that journey of recovery. Again, recovery. So we have over 100 adults now trained and certified as older adult peer support specialists. So we're really excited about that. I mentioned our Suicide Prevention Action Plan. I mentioned the statistics on older adults. So we do have specific activities aimed at older adults, like suicide prevention awareness campaigns. Those are things like recognizing the signs, symptoms, and where you can get help. Those are aimed at older adults and their caregivers as well. We have suicide prevention training that we're rolling out, again, for caregivers, folks who are at older adult centers, home health aid workers. We think it's really important, and I came in at the tail end of an interesting conversation. I wish I had heard it all, but part of, I think, what is obviously really challenging is understanding very confusing insurance and what Medicare can cover or not. So making sure that people understand how to maximize and use their benefit, and or where there might be people who will take their insurance for help. I already mentioned some of our grantees and programs are focused on, and some of the programs we do statewide are focused on increasing the knowledge, skills, and ability of our clinical workforce to provide better mental health and substance use supports for older adults. And we've focused some of our federal grant money. We got lots of federal grant money for opioids. We've actually focused it on safe storage and med disposal for adults. I mentioned 988 again, per 10,000 of the population, older adults are the smallest user Older adults are not using 988. So we have responded by developing some very specific 988 campaigns tailored to older adults and older males in particular. We'll see if that bears any fruit. And the last thing I want to talk about just super quickly are the grantees we had this year. And this is something we'll want to keep doing. Let me tell you how we approach grants, just so you know. So we send out grants, we fund as many as we can for as long as we can. We'll probably do a grant cycle again next year, right? So every couple of years we'll do a grant cycle. But we also hope not just to fund an agency to do good work. We hope they find a continuity plan in their community. We help as much as we can with continuity plans, but also we want to learn. Some of this for us is learning. We're learning what is effective, what is working well, how are we doing, how are we reaching folks, so we can replicate it through funding and other mechanisms. So we're super excited about our partnership with Southwestern Region A AAA. They have the Rural Connections program. This is just some of the ways that they are supporting their community very directly and indirectly, right? So they are providing services through older adult peer specialists. They are working with adults on social isolation, other ADLs. They are training and supporting family caregivers through respite, but they're also providing training and support and resources to families. So it's everything from recognizing mental health first aid, to actually here are other resources. Here's how you can use your insurance. So we really love everything that Rural Connections is doing. And again, we think a lot of this work is things that should be replicated in all communities. And we love working with the AAA. We like nothing better than like, you guys are the known trust. That's what I'm saying. You guys are the known trusted entity. Let us come to you. Let us give you the money, because that's where families are going to go, right? Families are going to go to you, not to our clinics. They're going to come to you. Great. Thank you. Thank you for letting us partner with you. And we would love for you to help them with social isolation or substance use and help their caregivers. We are also working with Appalachian State University. A lot of what they are doing is general training to the community. Mental health first aid, psychological first aid, or evidence-based models of care. They have been working on adapting these specifically for older adults. So they have completed that, and they are working on getting that information out. So getting that toolkit out to others. And then we are working with the Kellen Foundation in the Greensboro area. And again, they're training folks on mental health first aid for older adults. That's training for community members, right? Again, we need an informed society and community who can help an older adult who may have mental health or substance use issues, but they are also providing direct services through those older adult certified peer support specialists. They're also referring folks for mental health counseling when they need it. So I'm going to stop there. I probably didn't leave a lot of time for questions, but this is where I say, we are probably, 3 years ago when I met Joyce and I talked with Rebecca, we had the GAST, it was called the GAST program. And that's kind of the thing we had. We had a fledgling older adult peer support model. And so we knew at that point, we want to do more, and we're growing. We've got a dedicated team of Lisa. We've expanded our work and our outreach and our partnership with aging and adult services, but also community organizations and community-based organizations where adults go. And we hope to do more. And again, I'm just appreciative for being here, appreciative for you inviting Lisa into your community. And we always want to hear feedback about what's working and not, where gaps are, and what you think more we can do.
What a wonderful presentation. And your energy, enthusiasm, and commitment to, I think, doing these things is just comes through. I think you've just made such a difference in the work of the division the 3 years you've been there. Thank you for what you're doing. I see Gina Upchurch, you had a question. Do you want to ask that?
Yeah.
I don't know if Gina.
Sure.
Go ahead.
I'm hoping it's coming off now. So we hear as a SHIP counseling site, we hear from a lot of folks that their can't find provider. I mean, they've expanded who can be a mental health provider now, obviously. So I think that's huge and will increase access to care. But we have heard of people leaving Medicare Advantage plans because they can't find behavioral health folks that they've known traditionally. Are you all working on that, or what do you think about all that?
We
And
don't
thanks
have
for
a lot
thanks for
of,
your passion and work. Yeah.
Absolutely. We don't have a lot of influence over Medicare, unfortunately. Medicaid, on the other hand, is a different story. So that is a place where if folks who have Medicaid are not able to find practitioners who can support them, that's the kind of thing we can hear about and we can help. I think at the federal level, though, and Medicare, one of the things that, in my role, I can speak as much as I can, but one of the things I do like to talk about is parity. I think parity is a wonderful concept. It has not been actualized in any way, shape, or form. It just hasn't. But one of the things we're doing, I'll say, in the public system is we're still fighting the parity fight. And part of our parity fight is actually talking to the General Assembly and explaining to them how all the other health plans across the state do not have, there is no parity. If you have private insurance, there is no such thing as parity. You've got to jump through hoops. You have limited benefits. If you need mental health supports, there are very few therapists in network, and we need them to have stricter actual standards that they're verifying here in this state. I'd say the same thing about Medicare. But I think as much as you can do as advocates, I think people signed parity laws and they think we're done. We are far from done. Yeah.
Yeah, big challenge, that's for sure. Lisa, I don't know if you're still on or not, but could you just come off and say hi so people know who you are?
Lisa!
If you're still on. I don't see her.
Hi, everyone. Hello. Hi, everyone. Thank you for allowing me to be a part of this group.
And thank you for what you're doing. We really appreciate it. And thanks a whole lot. Anybody else have a question? I don't see any hands. I will ask one, and you may not know the answer to this. So we know there's a legislative study committee right now that's looking at involuntary commitment. Has your division been engaged in that at all? And where do you see
yes.
And where do you see things going relative to that?
Yeah, I mean, I would say, I could talk about this for a very long time. IVC is something we've wanted to work on for a really long time. It is incredibly unfortunate that these tragedies happened, period. It is, for these families and these community effectives, this is a horrific tragedy. There's also been a ripple effect, which has been almost to an increase in what we fear is people wanting to do even more IVC. We would argue that the problem we've been trying to solve is we have too much IVC in North Carolina.
Involuntary commitment, yeah.
Involuntary commitment, yes. We have a real kind of bad tradition here in North Carolina about people overusing involuntary commitment when people could easily voluntarily go to hospitals or crisis centers. IVC does have a role, and there are people sometimes who are at danger of harming themselves or others who do have lack of insight that just sometimes it is because the depth of their depression or psychosis do not even realize they need treatment. And so we understand that on rare occasions, IVC might be needed. We think even in occasions when it is needed, there should be clinicians as part of that process rather than just law enforcement and a magistrate. That's a terrible position to put them in. So the governor has tasked us, he's tasked our department with convening an IVC advisory group, coming up with recommendations for strengthening and improving the IVC process. So we all have a lot of thoughts around that. We'll be convening a group. And yes, that is sort of in addition to what the IVC committee is doing in the House. We have been part of that. We have presented on both involuntary commitment and outpatient assisted treatment, which is sort of involuntary commitment on the outpatient side, ways it could be used more appropriately and strengthened. So yeah, that's we could talk for an hour about that, but we do need reforms. But first and foremost, we just need to make sure that we have an understandable and available system for anyone who needs help. So we need mobile crisis teams that respond. We need people to use 988. We need people to know where their behavioral health urgent cares are, because for 99% of the population, that would actually work. It's trauma informed, it's staffed by clinicians. And part of the unfortunately the stigma we have, especially in older adults, is because mental health has for so long been linked very strongly with forced treatment, forced medications, justice involvement, transportation in handcuffs. I mean, so it's sort of like that's the history we're trying to get away from, not make stronger. Those are the kind of things that criminalize mental health and make people desperately afraid to seek mental health treatment. So many people are afraid that they'll get locked up. I hear that all the time. You're gonna lock me up. You're gonna make me take meds. You're gonna take my kids away from me. I hear that all the time. I mean, that's unfortunate. So like IVC can have a place, but what we really need is people to have a system they can trust and know how to find quite easily so they can get the treatment that they need. We need to make sure people that really need treatment, we have the good kind of system that people want to stay engaged in it for however long they need treatment, and that we have a good recovery system. So we don't have a lot of those components right now. Things are too fragmented. Families don't know where to find care. People go without care for too long. They are lost to care, and we're not following up. And instead of finding their way back to treatment, they find their way into the criminal justice system. That's what happens far too often. All that to say, yes, but at the same time, it's definitely a commitment of the governor to ensure public safety. But he thinks the best way of doing that, and I agree, is if we have a robust and strong mental health and substance use system, it works well, it does its job, and we coordinate really well with law enforcement. So they know, they trust us, they know how to use us, and we only use law enforcement when we need to.
Well, I think we could all say that with your leadership at the division and more awareness about what's going on, that we're hopefully on a good course and addressing a lot of those challenges that we've had as a state and as a country, for a very long time. But again, thank you so much for a very informative presentation and for all you're doing in your leadership.
Thank you.
So guys, that's it. Go vote. You've got today until I think 7:00, tomorrow until 3, and then on March 3rd. So do that. Thank you all for being here. We will see you in a month. So, and look for your newsletter this afternoon. Take care.
Thank you.
Bye-bye.